Good evening, all. I'm Zeena Chauhan from G Healthcare. On behalf of G Healthcare, I welcome you all today for this very interesting webinar on resolving the dilemmas in infertility management by our great faculties, Dr. Sonal Panchal, Dr. Manju Virmani, and Dr. Aarti Tolani. It's my privilege to introduce and welcome Dr. Sonal Panchal, who is also a moderator for today's session. Dr. Sonal Panchal is a consultant at Nagori Institute for Infertility and IVF, also professor at Dubrovnik International University, Croatia. She is also a faculty and national academic director in Ian Donald School in India. Her specialty areas are infertility, gynec, and high-risk obstetric scans with Dopplers and 3D, 4D ultrasound. She has been pioneering research. She has done pioneering research work in infertility and PCO-related ultrasound and presented published papers in national and international conferences and journals. She also has contributed a lot in and authored several books and reviewed peers journals. So now I would like to invite Dr. Sonal Panchal ma'am to begin today's session. Thank you.
Thank you very much, Zinat, for those very, very kind words. And it is my privilege to be a part of the G program. Thank you very much to G for providing us this platform to discuss our views on infertility and ultrasound. And I would right away introduce the first speaker, my very close friend, Manju Virmani, who has a very rich CV also. She is an MBBS from Lady Hardinge Medical College and Hospital, Delhi. Postgraduate in Radiology from Howard University Hospital, Washington, D.C. Fellowship in Breast Imaging and Ultrasound, Georgetown University Hospital, Washington, D.C. Board certification in Radiology from USA Diplomat American Board of Radiology. Major interest and work is in women's health, obstetric, gynecology, breast imaging, and she has a lot of interest in volume imaging. So she is an expert on 3D, 4D ultrasound, especially in obstetric, gynec, and breast imaging. She was a past president of Delhi chapter IFUMB, at present executive member of IFUMB and the Society of Fetal Medicine. She's authored a very nice book on breast imaging. She's involved in multiple CMEs in Washington, D.C. even today. And she is a director of Handa Imaging Center, New Delhi, India. Manju, so we would like you to talk on infertility, adenomyosis and infertility. Please, the dais is yours.
Thank you, Sonal. Thank you so much for your kind introduction. I don't think I deserve all that, but thank you so much. And I want to thank G for organizing this and having me to be with you all to speak on infertility platform. And I would also like to welcome you all and hope you're all doing pretty well in this unusual scenario of COVID. And we're still following the protocols of staying safe. Now, I'm going to be talking of ultrasound evaluation and infertility, and my basic talk is going to be on adenomyosis. We all know that infertility is defined clinically as failure to achieve conception during a 1-year period in which no contraception is used. It affects about 10 to 15% of women in reproductive age group. Female factor accounts for about 40%, and today I'm going to be talking on one of the acquired structural defects like adenomyosis, which is how it causes infertility or related to infertility. We also know that uterine abnormalities are associated with up to 10% of infertility. And in secondary infertility, the proportion of uterine abnormality increases to about 30% because these anomalies are acquired and may be caused by first trimester abortions, uterine instrumentation, and operative deliveries. Adenomyosis is defined as a benign invasion of endometrial glands and stroma from the endometrium into the myometrium, leading to these ill-defined lesions within the myometrium and also causing an increase in the uterine volume. There's this thing by this particular group who defines adenomyosis as the presence of endometrial glands in more than 2.5 millimeter surface area from the endometrium myometrial interface. In endometriosis, the endometrial tissue grows outside the endometrium into the ovaries and fallopian tubes, whereas in adenomyosis, the endometrium grows into the myometrium. Adenomyosis affects primarily above the age group of 35, but now because of the improved diagnosis, especially the ultrasound, endovaginal ultrasound, we have started seeing adenomyosis in the younger age group, which may be anywhere between 18 and 30, especially when they present for counseling on contraception and infertility. Clinically, they present with severe dysmenorias and dyspareunia. They are associated with abnormal uterine bleed, which may be in the form of menorrhagia or metrorrhagia, and they may be completely asymptomatic. On physical exam, the only positive finding is an enlarged uterus. Now, it's very important to understand the relationship of adenomyosis and infertility so that once we diagnose, our clinician can inform their patients of all possible treatment options. What adenomyosis does is it impairs the uterine contractility and affects the sperm transport. And there is anatomical distortion of the uterine cavity. It's an irregularly enlarged uterus which obstructs the tubal ostia and interferes with the migration of sperm and embryo transport. Also, there's thickened junctional zone which further impairs fertility by disturbing the peristaltic contractions and therefore the transports of the oocyte and sperm. Then there is hypoplastic muscular tissue, which can cause dysfunctional uterine hyperperistalsis, and it may also trigger an abnormal inflammatory response. 90% of women who are younger than 36 years of age may have pelvic endometriosis, and they have a very, very strong association with adenomyosis. Here we can see a uterus, asymmetric thickening, pretty heterogeneous myometrium. And there is bilateral endometriosis, which we can see. And in these patients, adenomyosis is thought to be the cause for infertility. Then adenomyosis is also associated with other uterine anomalies, like here's again another focally enlarged uterus or a globular uterus with focal enlarged thickening of the myometrium, bilateral endometriosis, and this lady also had multiple fibroids, and it has been seen about 38% of patients with adenomyosis may have fibroids associated. They can also show endometrial hyperplasia, which is picked up in about 31% of patients. Adenomyosis can interfere in vitro fertilization programs by disrupting implantation, and these implantation failure may be because of increased thickening of the junctional zone, or they may affect the endometrial receptivity. There's been known that there is some leukemia inhibitory factor, and the gene for embryonic development is lower in these patients with adenomyosis. So it interferes in the vascular flow in the uterine cavity. Now, there's a diffuse type where there's diffuse enlargement of the uterus. It involves all the muscle layers of the myometrium, as we can see here. Now, this has to be differentiated from myohyperplasia. Then there could be focal adenomyosis, where there is focal asymmetric enlargement of the uterus or the myometrium, and only a part of the myometrium or one of the walls of the myometrium can get affected. Now here they have to be differentiated from the fibroids. Now pathological classification is when superficial when it reaches the inner third of myometrium and deep when it reaches the outermost third of the myometrium. The earlier diagnosis of adenomyosis was made only on the pathological specimen after hysterectomy. Whereas now, with improvement in ultrasound technology, the diagnosis of adenomyosis can be made in the clinical, ultrasound department. So there are multiple features which we see on an ultrasound, and we will see how on these images how we can rule out adenomyosis. One of the commonest presentation is increase in uterine volume. There may be diffusely enlarged uterine cavity, as we can see in both these two different patients. or there may be focal enlargement of the or asymmetric thickening of the myometrium. Here we see it along the posterior wall, and here we are seeing as a focal thickening along the fundal region. Then there is this heterogeneous myometrium, which actually is the most frequent and a very, very sensitive sign. It manifests before increase in uterine volume and is seen in almost 84% of positive cases. Now here what happens, we have two different examples and we can see that the myometrium looks extremely heterogeneous. There are these tinier and linear echo densities. There are these small cystic areas. And then this is a classic pattern which is called the streaky appearance, or there is this Venetian blind appearance it's called. Both these examples show these thin vertical lines which are coming out into the myometrium from the endometrium. These myometrial cysts are generally small cysts which are measured between 1 to 5 millimeters. They're small, round, and these are nothing but the ectopic endometrial glands, and is one of the sensitive signs. And all these three images are different patients. We can see subendometrial cyst. Here we can see a myometrial cyst, and here there's focally thickened endomyometrium with multiple small cystic areas. The other thing which we commonly see is these echogenic subendometrial nodules. We can see here, and again in this patient, they're multiple. When we see this heterogeneous mottled appearance, as this is one patient with same images, different images on the same patient, showing us a very abnormal looking myometrium with multiple cystic areas, with multiple echogenic nodular densities, and a streaky and a striated appearance of the myometrium. This is another patient, they can show a globular uterus, and there is loss of myometrial endometrial interface. Here we see an asymmetric posterior wall. Again, there's poorly defined myometrial endometrial interface. When we see all these things, this is described as cirrhosis of the uterus. There's this question mark sign, which again we see, and that's because the uterus is retroverted and the cervix is just anterior to the bladder, and that gives the endometrium, which when we trace it, it's difficult sometimes to trace, and this is called the question mark sign, how we can trace. And we can see in all these four different examples, even in an anteverted uterus, we appreciate this question mark sign. Indistinct endometrial myometrial junction and loss of definition of endometrial myometrial transition is characteristic of adenomyosis. And this we see as the subendometrial echogenic linear striations, which radiate out of the endometrium into the myometrium, and they are very nicely seen in both these examples. Then there is loss of myometrial endometrial interface. All of them are showing loss of myometrial endometrial interface. There is increased thickening of the junctional zone, and another one of the examples for thickening of the transition zone. These are all 2D images which show us the characteristic features of myometrial endometrial interface. Abnormal, this thing which is pretty much characteristic of adenomyosis. When we have 3D, what we look for is this junctional zone, which is seen as this hypoechoic halo around the endometrium. Even if there is any deformity of the endometrial cavity, still the myometrial endometrial interface is what we look for and is nicely seen as in this particular patient of polyp. But here, when we do 3D in the adenomyotic patients, there is just complete loss of myometrial endometrial interface. There is interruption of the junctional zone, as in this particular patient. We can see lateral wall looks all right, but there is complete loss along the left anterior margin. This appears irregular. Here we can see a complete irregularity along the right lateral and the anterior margin. Sorry, so, and also these are two different patients which show complete loss of the endometrial myometrial interface along the anterior margin, and there is irregular thickening of the junctional zone. This was subjective. What we did was all subjective evaluation of the myometrial endometrial interface. We can also do certain measurements. And here what we do is we measure the junctional zone, which is perpendicular to the endometrium. And this is actually very nicely done on 3D. This just shows us a multiplanar format where we can define the junctional zone and measure it. We can measure the maximum thickness, which is where the junctional zone appears to be thickest. And we can measure the minimum thickness where it appears thinnest. If the junctional zone is ill-defined or not visible, it should definitely be reported as not measurable. So here, when we look at the thickness, we take 8 to 12 millimeters, which is suspicious. More than 12 millimeter is an accepted criteria for diagnosing adenomyosis. And here we can see a loss of myometrial endometrial interface, thickened endometrial zone, and here again a very, very thick junctional zone. MR is pretty accurate. The specificity and sensitivity is higher and is actually better than ultrasound. But with the improved technology, I think we would start doing an endovaginal ultrasound, and I'm sure we'll be competing with MR when we are doing that. We can also, when we measure the thickest and the thinnest portion, the difference between them, if it's more than 4 millimeters, that's also indicative of adenomyosis. So the significance of this thickness of junctional zone, it has been seen that it is greater in patients with endometriosis. Then there's this journal, European Journal of OBGYN, said that if the junctional zone thickness is less than 2.7 millimeter, the pregnancy outcome or implantation is much better. A similar result, which was published by this particular journal, who said that if the junctional zone is thick, there is a less likely of the successful implantation in ICU cases. Focal adenomyosis is when there is only a single uterine valve involved, or there is focal involvement. As we can see here, there's just posterior uterine wall looks absolutely abnormal. When it forms a nodular sort of a feature where it forms like a round, poorly defined mass, it may be like focal adenomyosis or it may be an adenomyoma. And these adenomyomas are poorly circumscribed. They are very, very heterogeneous. They show cystic areas, and again, we can see this streaky appearance. There's thickening of the junctional zone. There's loss of myometrial endometrial interface. And one of an important feature is that when we examine them, patients generally are tender and they go on complaining it's painful, it's painful. This has to be differentiated from an intramural fibroid. And actually, I put this image because if you look at this image, you may still have a doubt, okay, this and this are almost similar. But when we look at the margin, it's very well circumscribed. And when we do a 3D, we can see a very nice myometrial endometrial interface. And we see that it just shows a mass impression without distorting the cavity. So these are well circumscribed. The texture may be hypo or isoechoic. There is shadowing involved in it. And they're generally not tender. Focal adenomyomas, when we look at the color flow, they generally have a very prominent central vascularity. And earlier we used to describe them as spoke wheel, where there's a central dominant vessels and there are vessels irradiating out of it. This is another example of focal adenomyoma with increased vascularity. When there is a diffuse involvement, then we see a marked increased vascularity with multiple tortuous vessels which are penetrating into the myometrium. And these are two different examples of this. The modalities which are available for us to evaluate adenomyosis, ultrasound and MRI. This is an endovaginal ultrasound, and this actually has all the features which we just went through, with echogenic nodules, cystic areas, streaky pattern, loss of myometrial endometrial interface. And when we have pictures like this, we have a very high sensitivity and specificity. And MR, as I always say, is a problem-solving modality and is a method of choice in only suspicious cases, because they may have a higher sensitivity and a specificity. But I think if we use all our ultrasound applications which we have, I think we don't think we need to send the patients for MRI. Now, transvaginal ultrasound should be considered a primary imaging modality, and establishing an accurate diagnosis with ultrasound may be the first step in patients' fertility journey. Thank you so much for having me here, and I would like to end my presentation here. I'll stop sharing my screen, and Sonal, I'll pass it on back to you.
Thank you very much, Dr. Manju, for that excellent presentation and lovely 3D pictures, I must say. We really enjoyed it. And please stay back with us for some expert opinions on some infertility cases after Aarti and me present. So please be with us, and we really enjoyed your talk. Going to invite Aarti now. Aarti, I'm sorry, I'll not be able to tell you, Dr. Aarti, you are so close, so near. In fact, both of you are so near and dear to me. But to introduce you formally, Aarti is a clinical director, fertility specialist, and scientific in charge at the Mamta Fertility Hospital since 2009. She is a member and secretary of the Institutional Ethics Committee of Infertility Institute and Research Center, Hyderabad. She is faculty at Kiel School of Reproductive Medicine, Germany for diploma course in reproductive medicine, faculty for diploma course in OBGYN ultrasound at Dubai in 2018, trainer at Foxy recognized course in basic infertility management, Bansal Hospital, Bhopal, actively involved in organizing and co-conducting several conferences. National award, she's received a national award for budding IVF champion of the year 2019 by the Economic Times National Fertility Awards in October 2019 at Delhi. Young academic star in the field of infertility in South India by Star Time Media National Healthcare Awards 2019. Young Achiever of the Year in the field of infertility by India's Best Doctors 2018 and 19. So Aarti, 2018 and 19 has been a real eventful year for you. And gold medalist, Best Oral Paper Award for endometriosis in infertility at the National Ultrasound Conference at Hyderabad 2010. She has more than 20 publications in national and international journals and textbook. And Aarti, we would like you to talk on ultrasound assessment of ovarian reserve. Welcome, Aarti.
Thank you, madam, for that very kind introduction. And it's an honor that you are introducing me, really an honor.
Thank you.
And I'm the odd man out, as I mentioned earlier. I'm the gynecologist among stalwart radiologists like both of y'all. And I take this opportunity to say hello and welcome to the delegates of this webinar on resolving dilemmas in infertility management. So I'll just share my screen and start my talk, ma'am.
Please.
So can you see my screen, ma'am?
Yes, thank you. Yes. Go ahead.
So we would like most tests in our medical practice to be simple, uncomplicated, fast, efficient. A test should give you all the answers, easy to interpret. In other words, this is how I would want, all of us would want a test to be. Just press a button and it's done. As simple as that. But the truth is, it's never that simple. It's much more complicated than what it seems. So in the test for ovarian reserve 2, we have biochemical, we have ultrasound, we have dynamic tests, we have the issue of overchoice. But among the available options, of course, AMH and AFC stand out, proven and time tested. But today our topic will be limited to the ultrasound parameters, namely antral follicle count, volume, and ovarian blood flow. So when I was asked to talk on this topic, on the role of ultrasound in the assessment of ovarian reserve, I asked myself, what else can I possibly tell you all about ultrasound in the assessment of ovarian reserve, what you already do not know? And then I told myself, it's always good to review what we know, review the basics, the step-by-step method to assess the ovarian reserve by ultrasound, see what the latest technology can offer and how we can put it to practice. So let me start with the basics. The ovary is a wonderful organ. It's one of the most active organs in the body where the ovarian cycle is repeated month after month.
Now, women are born with the maximum quota of primordial follicles, which constitute the true ovarian reserve. Now, understanding the different classes of follicles is very important before we go ahead and discuss ovarian reserve assessment in detail. So, we have the primordial to the preantral follicles, which are the class 1 follicles, and these are less than 2.2 mm in size. And then come the class 2, class 3, and the class 4 follicles, which are the early antral follicles, and these range between 0.2 to 2 mm in size. And then we have the class 5 and the class 6 follicles, which are the medium sized antral follicles, that is the ones which are visible on ultrasound, that is the 2 to 10 mm follicles, and these are the class of follicles which
Sorry
we are
to disturb, ma'am. Can you switch on your camera, ma'am?
yeah.
Yeah, your video is muted. So.
Yeah, can you see me now?
Yes, thank you.
Yeah, yeah. So then we have the class 5 and class 6 follicles, which are between the 2 and 10 mm follicles, which are visualized on ultrasound. And we have then the 7 and class 8 follicles, which are the larger sized follicles and the pre-ovulatory follicles. Now, a mention over here, when I talk to you about Sono AVC, this technology helps us further regroup the follicles, the antral follicles, into 2 to 4, 4 to 8 mm follicles, and these are the recruitable follicles and the follicles which are gonadotropin dependent, and these are the ones which will actually respond to your ovarian stimulation. Now, what usually happens in an ovarian cycle is these primordial follicles continuously undergo depletion throughout the woman's lifespan, and these primordial follicles are recruited to antral follicles through a series of developmental stages, that is the primordial, primary, and preantral follicles, and then eventually these antral follicles grow and many of them undergo atresia, and finally a single dominant follicle develops from one wave per menstrual cycle. So if you can see over here, the AMH is secreted by the invisible pool of follicles, that is the primary, preantral, and the early antral follicles, and the antral follicle count represents the visible pool of follicles, that is the 2 to 10 mm follicles. So why do we need ovarian markers? Why do you want to assess ovarian reserve? It is because in the field of infertility, we want to predict outcomes. We want to facilitate individualized medicine. We want to indicate the response to treatment. We want to choose the right drug for the right patient safely, efficiently, and maximizing the chances of pregnancy. Ovarian reserve assessment is also done for diagnosis of certain disorders, before fertility preservation, in case of social oocyte freezing in oocyte donors, before a woman undergoes a gonadotoxic treatment, prior to reproductive surgery, and so on. So why is counting ovarian follicles important? Because as I just mentioned, we want to know what is the functional ovarian reserve. We want to know what are the risks associated with stimulation. And we also want to use this as a predictor of IVF outcome. Now we use this percentile nomogram chart as per the age in our ultrasound units, and these nomograms provide a reference guide to the clinician in consulting with the women with infertility. So over here you can see, when you know that the woman is in the 3rd percentile, these are the women with poor AFC and they usually reach menopause earlier, and if they are in the 75th percentile or higher, they are the one who will reach menopause much later. Now, what are the minimum ultrasound requirements which we need? We need we need to do a ultrasound assessment using a transvaginal probe with a frequency of at least 7 megahertz. and the operator should be able to adjust the machine settings in order to achieve the best contrast between the follicular fluid and the ovarian stroma. Now, moving on to what are the different technologies which are available to demonstrate antral follicle count. So we have the 2D real-time ultrasound, which is used standardly in routine clinical practice, relatively quick. When the follicle number, but the only problem is when the follicle number increases, the accuracy of 2D techniques decrease because we lose track of counting the follicles, and there is a chance of overcounting the follicles. Now, and then we have the 3D manual mode, that is the multiplanar view with VCI or without VCI. I'll talk about it a little bit more in detail in the coming slides. Then we have the inversion mode, which is another mode to count the antral follicles. And then we have the Sono AVC antral, which is automatic software which helps us color code and count the follicles. And this helps us in preventing missing counting many follicles which would have been missed in 2D ultrasound. Now, why is all this important, all these technologies? Because we want to then classify the patient as having a poor reserve or a normal reserve or a high reserve or a polycystic ovarian morphology. That is, we know that when we see antral follicles less than 3, the number, that is the follicular number per ovary less than 3, we know we are dealing with a patient with poor ovarian reserve. We know when the follicle count is between 4 to 19 per ovary, we are dealing with a normal ovarian reserve. And when the follicle count is more than 19, we know we are dealing with a high ovarian reserve. Now, coming to 2D ultrasound, what do we need to know? The operator should scan the ovary in both the longitudinal and the coronal planes to identify which offers the better image. And when needed, to improve the quality of the image, the harmonics can be put on. To optimize the image quality, the ovary is put in the center of the screen. It should occupy 50% of the screen along its longest axis. Any color can be used as long as there is minimal noise and clutter. The follicles should be imaged as clean anechoic area, and then we start counting the follicles by the technique of eyeballing, where we are counting all the follicles when we are moving our probe from one end of the ovary to the other. Now, when we are counting the follicles, we measure all the follicles between 2 to 10 mm in size, and when in doubt, that is when we feel that the follicle which we are counting is either less than 2 or more than 2, we measure those follicles. If the follicle is oval, we take 2 measurements. If the follicle is round, we just take a single measurement. Now, remember, real time is always better than offline for determining para-ovarian cystic structures. Remember, 2D ultrasound is operator dependent, so I always prefer real-time 2D ultrasound. Now, Cineloop 2D ultrasound is another modality where a single continuous sweep of each ovary can be taken. These loops are stored and they can be replayed, but again, it is operator dependent. Now, few other aspects of a 2D ultrasound. The timing of the ultrasound preferably should be done in the early part of a natural cycle where the patient has not taken any OC pills in the previous 2 to 3 months. Use Doppler when in doubt. Now, we prefer the early part of the follicular phase because we know when done later, the presence of a luteal, an ovarian cyst or a corpus luteum might mask some of the antral follicles. The follicle count, if assessed in a woman who has taken oral contraceptives or other hormones, we must know that it might cause a false decrease in the antral follicle count. That's why I mentioned that it's preferable to be done in the early part of the menstrual cycle in a woman who's not taken hormones in the last 3 months. And we must be careful when counting or interpreting an ovarian follicle in the presence of an adnexal mass or an adhesion or pelvic loculated fluid. Now, also know that in the presence of endometriosis or adhesions or previous pelvic surgery, and if the ovary is far away from the probe, again, this might cause the antral follicles not to be counted correctly. Now, when we are using the multiplanar technique for counting antral follicles, again, the ovary is scanned in 2 planes, and the one which appears more elongated with the maximum number of antral follicles should be taken while taking the 3D sweep. Sweep angle should be 120. Acquisition of the 3D data sets of the ovary should be quick. This usually reduces the scanning time because you're doing 3D sweep. After the 3D data set is acquired and stored, the follicles can be counted offline. While using the multiplanar mode, you can count the follicles in all the 3 planes, and it can be cross-checked in all the 3 planes. Now, VCI again is an additional way of improving contrast enhancement and speckle suppression, providing better definition to the follicles which we are imaging. As I mentioned, it improves the image quality on 3D ultrasound, similar to harmonics used on 2D. Now, coming to the inversion mode. Inversion mode is a rendering mode which inverts the echogenicity, turning the darkest points into the brightest ones and vice versa. You can look at the arrangement of the follicles. You can count the follicles, though it is a manual technique and time taken. Now, the only limitation is that any surrounding hypoechogenic structure in the original image will make it difficult to identify the follicles, and that is the reason why you must use vocal, so that you can actually define what is your region of interest and exclude from the region of interest all the other structures, so that you can improve the identification of ovarian follicles within the ovary. You can also use the surface rendered mode, so that you can visualize the 3D arrangement of the follicles within the ovary. This is one of the beautiful images of the ovary after doing the inversion. Now, also it was noted that the AFC performed using inversion mode was better correlated with the number of oocytes retrieved following ovarian stimulation than compared to AFC done on 2D or multiplanar view. Now, coming to the Sono AVC, which is mine and many others' personal favorite. Now, Sono AVC allows counting and measuring of the diameters and volumes of the anechoic structures within a region of interest of an acquired 3D data set. And as I mentioned earlier, you have further subgroups of these antral follicles. That is, this software further classifies, the range of size ranges of the follicles between 2 to 4 and 4 to 8. And as I mentioned, the 4 to 8 mm size follicles, they correspond better with the number of oocytes retrieved in an IVF cycle. And these subgroups are further color-coded and numbered So over here, again, the region of interest should be adjusted in order to exclude as much as unnecessary tissue as possible. The only issue is that you do require, it's not as easy as the press of a button. It does require a little manual processing, that is, including those follicles which have not been included. It is just by clicking a button you can include it, and those which have unnecessarily been included in the sweep also can be then removed when you are doing manual processing after taking the 3D sweep. So it is not perfect, it is frequently imperfect, but with a little a little work, just extra work, you can get the perfect picture. Now, coming to assessment of ovarian volume, to calculate the volume of the ovary, you can do it on 2D or 3D. Now, 2D everyone knows, but more importantly, again, ovarian reserve, the volume evaluation helps us to classify the patient into a poor normo or hyperresponder based on the volume of the ovary. When you are doing a 3D sweep, you get the images in 3 planes, and then using a software called Vocal, you perform a volume assessment of the ovary with rotation steps of 30 degrees. And then finally, the 3D rendered image is this, what we get. It's more useful, especially in patients who do not really have the perfectly spherical ovaries. So we've completed AFC. We know what are all the methods of assessing antral follicle count, right from the basic 2D to the most advanced Sono AVC antral. We then move ahead and do the ovarian volume assessment in 2D. And if you have a 3D machine, I love doing the 3D volume assessment. And then finally, you do a stromal vascularity check. Now, why is stromal vascularity important? Because it tells us about the response. It tells us about the amount of blood actually reaching that ovary. It tells us about how easy is it going to be to stimulate that ovary. Now, the color signals are sort of in the stroma, the maximum distance from the surface of the ovary. The PRF should be set at 0.3. And then a pulsed wave Doppler for quantitative assessment is done, where we then want to assess the RI and the PSV. Now, why is this important? Again, as I mentioned, it tells us about how easy is it going to be to stimulate this ovary. Lower RI and a higher PSV are usually indicative of a nice responsive ovary. And finally, once we have completed the assessment of the antral follicles and the volume and the stromal blood flow, we then give a standardized report where we include what all we have scanned and our findings. Now, remember, AMH and AFC are like two faces of the moon. They are synergistic biomarkers. AMH and AFC are synergistic because they have similar strong associations with the size of the primordial follicle pool and the follicular recruitment rates. Both reflect the 2 to 6 mm follicles seen on ultrasound that secrete AMH. The circulating AMH reflects usually the output of all the granulosa cells within the follicles, but then this production is not consistent. But because determination of AFC relies on ultrasound, this is a bedside tool in IVF units, and it has been suggested that AMH and AFC should be used complementarily in a pre-IVF assessment. So to end, what should be the stepwise approach before we do a dose calculation? Now that we have all this information of AFC, of volume, of stromal vascularity. So what is the stepwise approach? We do a 2D, we look at the follicular number per ovary, then we do a 3D Sono AVC so that we get a more precise antral follicle count. We even get the grouping of the follicle sizes. Then we do a 2D or a 3D volume assessment. Then we do a stromal vascularity check, look at the RI, the PSV. Based on this information, we now know whether we are dealing with a predicted poor responder, a normo responder, or a high responder, and based on this information we can design a proper ovulation induction protocols. Now these are the basics. If we see a patient with a lower RI, a higher PSV, a high antral follicle count, high ovarian volume, thin woman, young woman, we know this is a patient who requires lower doses of medication to stimulate compared to the opposite who will require higher doses. Now, based on this is again Dr. Sonal ma'am's beautiful normogram, which I always use. I keep it at my ultrasound unit pinned on the wall. And this example, which I just showed you of this patient who had a polycystic ovary, and based on the score, based on her age, her BMI, and what all I have noted, that is her antral follicle count, her volume, her RI and PSV, we give her a score, and based on this score we can decide on the starting dose of recombinant FSH for an IUI cycle. And there is also a similar normogram for patients undergoing IVF, and again based on your total score we can decide about what is the starting dose of gonadotropins for the IVF cycle. Now there are many other normograms which I'm not going to get into, but this is only to show you how using these ultrasound parameters is important in calculating the dose of gonadotropins. This is a Popovic's normogram, again utilizing all ultrasound parameters. This is Lamarca's normogram, again utilizing all the ultrasound parameters to give you what is the starting dose of gonadotropins to be used. The AMH versus antral follicle count for defining the starting dose, both are equally important, but just a point to note, AMH is better than AFC for predicting hyporesponse. Conversely, AFC appears to be a better predictor than AMH in predicting hyperresponse. But it must be remembered that AMH and AFC may predict ovarian response, but not live birth rate. So as you can see, no marker is perfect, and AMH and AFC is no exception. So with the emergence of the ability to measure AMH and AFC, this has added great spice into our daily practice and research. Thank you, ma'am.
Thank you very much, Aarti. It was very a lovely talk and a complete talk on antral follicle counts and ultrasound markers of ovarian reserve. I will now continue with, and Aarti, please stay with us for the panel at the end, because the title, as you know, is Resolving Dilemmas in Infertility, and we are going to discuss all the dilemmas in the panel. So please be with us, and I will continue with the next session, and that is on Tubal Assessment. Can you see the screen? Hello?
Yes, ma'am, we can see you.
Thank you. So to start with, I know there will be radiologists with us, there will be gynecologists with us. For gynecology and the infertility people, this is not a new fact, but I would just want our radiologist friends to revise or remember that fallopian tubes are not just portals, they are not pipelines through which the ovum is going to travel. They are active components responsible for the fertility and the fertility potential of the patient. We know that the tube has its cornual end and it has a femoral end. The femoral end is what is very supple, and that's the active most component. It has to be placed close to the ovary, so not just the patency of the tube-ovarian relation is important. And what actually happens during the ovulation is really a miracle. The fimbria, they come and overlie they cover the ovulation site of the ovary, there is a negative, so they're well opposed to the ovary, and there is negative, there is a ciliary movement in the columnar, in the epithelium inside, which leads to a negative pressure, which sucks the ovum from the ovary. That means it is very, very important to understand that the tube, patency of the tube is not just enough. You have to know about the tube-ovarian relationship. You must know that the tube and the fimbria are supple and mobile, and the entire tube condition, the mucosa inside is normal, so that the ciliary movements and negative pressure is creation of the negative pressure is possible. So that means these active organs need a close observation. Any pathology in it at any point of time may have damaged the internal epithelium, and in spite of the fact that they look normal, otherwise on ultrasound there is no hydrosulfins, but still they may be not functionally normal, and therefore the tubal pathology, the tubal assessment is very important part of the infertility assessment. As far as the ultrasound is concerned, we can assess the tubal pathologies by ultrasound, and the patency of the tubes can also be assessed by ultrasound. When talking about the pathologies of the tube, of course, fallopian tube tumors are quite common, but not as common as the inflammations. The inflammation of the fallopian tube is a very, very common pathology found, and the inflammation may be acute or chronic. So we may be looking at an acute salpingitis or a chronic salpingitis. And starting with acute salpingitis, any inflammation will lead to thickness, that means edema and swelling, which leads to thickening of the tube if it is about the tube. It leads to hyperemia because of neoangiogenesis, so it leads to a lot of vascularity, and it leads to inflammatory fluid, so it also leads to free fluid. So the diagnosis becomes very easy when you already have some free fluid in the pelvis, and along with that you can see the thickened tube with absolutely edematous fimbria, and also hyperemia, a lot of blood vessels seen on the power Doppler in the tube. So that is one of the pictures. You may also see, here in this picture also, you're seeing a thickened fimbria. You're seeing thickened fimbria there, you're seeing thickened fimbria here floating in the free fluid, and you are seeing the entirely thickened tubal lumen, and along with a lot of vascularity in the walls of that 3D power Doppler picture. That is also an acute salpingitis. If there is free fluid, as we have seen in the previous two pictures, you can render the image and you may beautifully see the entire thickened tube floating in that fluid. That is one additional evidence of an acute salpingitis. You may see the ovary and you may see the fimbria by the side of it, and if you see a lot of vascularity in it with a little bit of fluid also, you suspect there is a possibility of an acute salpingitis. You can beautifully render that fimbrial, and you are seeing there are some fibria which are nice and good, but there's some which are thickened and inflamed and even pruned. And you can use HD Live with Silvage to see that. And if you put on the 3D power Doppler, if you put on a power Doppler and take a 3D, beautifully hypervascularized fimbria are seen. So again, an evidence of acute salpingitis. Why I am showing you all these evidences of acute salpingitis is because most of the times in our practice we miss acute salpingitis. That means if there's hydrosalpinx, we would diagnose it as an abnormal tube. It's very, very important. Whenever there is any tenderness, any feeling of non-well-being, mild pelvic pain, free fluid, and unexplained infertility, otherwise the rest of the things appear normal, and still the tubal fracture does not appear evident because of lack of hydrosalpinx. Acute salpingitis is a very important thing to be diagnosed. You may, and that is why I'm showing all these different ultrasound signs of acute salpingitis. You may see a thickened tube floating, Along with that, even on 2D, you can see that tiny lumen with very thick walls. So that is again a sign of an acute inflammation. And when seeing on surface rendering, you can beautifully in that see the, I'm sorry, and beautifully in that you can see the inflamed tube floating. You're seeing the thickened, the large diameter, where the hydrosalpinx is still not evident because it's chiefly because of the wall thickening. You may also see hydrosalpinx, mild hydrosalpinx, and if the walls are absolutely thickened, you can see beautiful thickened walls here in a tortuous tube, in serpiginous tubes. Look at that. And that is also acute hydrosalpinx. So it's an acute inflammation along with hydrosalpinx. And again, the walls are showing hypervascularity, which is an additional sign. Whenever you see any extra ovarian cystic lesion, it is essential to see this lesion in two orthogonal planes. In fact, any lesion in the body has to be seen in two orthogonal planes. But when we are talking about an extra ovarian cystic lesion, it may appear absolutely rounded and like a cyst on one plane. But when you rotate the probe, either a beak-like projection will be seen outside, arising out of it, or you may also see its elongation. And if you see a typical incomplete septum sign, you are very sure it is a hydrosalpinx. Hydrosalpinges, as I told you, that is the previous picture showed us this one is a typical book picture of hydrosalpinx, but hydrosalpinges may have variable appearances. In this case, you can see thickened hostra and mucosal folds because of the edema, along with the thickened wall of the hydrosalpinx, and it is narrowed onto one end, whereas it is wide open on the other end. So that might be close to the femoral end, and that's the cornual end. You may also see hyperechoic or you may also see some echogenicities, low-level echos or ground glass-like echogenicities in the dilated tube, and this may be because of blood or pus. It is very important that unless you actually see a layering, as you were seeing here, unless you actually see the layering of the fluid, which indicates this is blood and blood products, or there is a definite history of either acute severe inflammation or an ectopic or a hemorrhage in the tube, you should not on ultrasound document it as a pyosalpinx or a hematosalpinx. So if there is a definite history, if there is a layering effect, then you may say it's a hematosalpinx. But if you don't have a definite history, it's better to write down as hydrosalpinx with a thick fluid inside, and you have to confirm what the contents are. The hydrosalpinges may be very tortuous and may appear like multiple cystic areas. If you do a routine 2D scan, even on 3D, it may not, even on the transverse section, it may not show the continuity. So in this case, it's quite easy to diagnose because you are seeing those spikes because of thickened hostra. But if it is a chronic hydrosalpinx, the walls may appear quite smooth and there are no irregularities in it, and it is very difficult to differentiate this from other extra-ovarian lesions which may have cystic consistency. And in this cases, you can do a 3D ultrasound either on coronal plane, multiplanus, or on inversion mode, or on minimum mode, or on inversion mode, may show the complete continuity of the tube and establishes your diagnosis. Similarly, here also you can see that multicystic lesion is actually a hydrosalpinx. You can also do a surface rendering and look inside the tubal lumen, or you may also walk through and observe the entire extent of the inflamed or the hydrosalpinx, inflamed hydrosalpinx tube, hydrosalpinges. The waist sign. The waist sign is a typical sign of hydrosalpinx, which you can not only see on 2D, but you can beautifully demonstrate the two waists here. You can demonstrate that on a 3D ultrasound. Inversion is a nice mode to look at the the hydrosalpinx. Aarti has beautifully described the importance of and accuracy of the inversion mode for the follicles, and that is true for any of the cystic lesions. These are all the pictures. These were all the pictures of acute salpingitis and hydrosalpinx because of acute inflammation. Moving to the chronic inflammation, we know that chronic inflammation is it leads to fibrosis and it leads to adhesions. Because of the fibrosis, the walls of the hydrosalpinx become quite rigid. As you can see here, they are hyperechoic also, and therefore over distension of this lumen, this hydrosalpinx lumen is not possible. These are typically chronically inflamed tubes. There is the hydrosalpinx remains as such. There may be adhesions. You can see an ovary very close to it. And on the inversion mode, again, you are seeing the entire tube, and that is a follicle. Because of the inversion mode, the follicle also is appearing solid. You can also use a Sono AVC, which is sonographic automated volume calculation, to actually calculate the volume of the hydrosalpinx. One more, chronic hydrosalpinx, typically again very hyperechoic walls, not very thick ones, no irregularities inside because it has undergone fibrosis. And that is also a case of chronic hydrosalpinx. That's one and two different locules of hydrosalpinx. When the inflammation proceeds further, we know that hydrosalpinx is almost always associated with oophorytis, and oophorytis is otherwise difficult to diagnose because you might have not measured the ovarian size. Of course, it's true that when it is oophorytis, acute oophorytis, there will be increase in the size of the ovary because of edema, swelling, and because of edema and swelling, the stroma will appear hypoechoic, and not only that, it is hypervascular because of the hyperemia of inflammation. As the inflammation proceeds, if it is not countered by either exogenous drugs or by self-immunity, then it will proceed into increase in the inflammation and fusing of the tube and the ovary because of inflammation, and this is called tubo-ovarian mass, as we know. When you press the probe in and out, you will not be able to separate the tube and the ovary, and that tells you it's a tubo-ovarian mass. And tubo-ovarian masses can be well demonstrated on 2D also, but 3D may also help to show the entire shape. And there are many more pictures for the tubo-ovarian masses. You can see again the ovary and the entire tube here. In both these cases, you can still beautifully see the ovarian outline, and you can define the tubal outline. So these are tubo-ovarian masses. When the septa in between, they break down because of inflammation, we then call them tubo-ovarian abscesses. You can also use Silhouette mode to show the entire tubal lumen along with the irregularities in the wall. You can see there's no definite regular pattern in this inflamed tube. You're seeing absolutely rough and irregular wall of the tube inside, and you are also seeing the ovary. So because of the transparency, you can make out that this is the ovarian margin with the follicles there, and both the things are overlapping. In chronic tubo-ovarian abscesses, you may see beaded appearance of the tube and the ovary attached to that. And you may also, there's one more case where again you have a tubal mass and the ovary attached to that, and that is again a tubo-ovarian mass. Now, that is all about the pathologies. Now, coming to the second part of the talk, and that is about the tubal patency assessment. We know there are a lot of tests which have been done over the years, which have been found, which have been invented over the years, like Rubin's test, hysterosalpingography, HSG, hysterocontrast salpingography, HICRC, saline infusion salpingography, positive contrast salpingography, and of course, laparoscopy. Rubin's test is already obsolete now. Hysterosalpingography has been used for years and years together. It was a little less in fashion and little outdated for a few years, but with new inventions in the X-ray technology, in the radiology, the HSG has again become one of the important investigations, and it can show the entire endometrial cavity beautifully, the tube, entire extent of the tube, and it can also show the spin. So it is one of the tests which is widely used for the assessment of the tubes, in spite of its disadvantages of using the iodinated dye, which has a high chance of adverse reactions, in spite of its risk of X-ray exposures, and it's also a bit painful, but still it does show the tubal pathologies very well. As you can see, hydrosalpinx here, distal hydrosalpinx here. You can also make out the uterine abnormalities like synecdoche and polyps, and therefore is an investigation which is still widely used in most of the places. Laparoscopy, of course, is a gold standard because it not only tells about the tube, it also tells you about the tube-ovarian relationship. It shows you the fimbria line, which is a very important observation and finding. But sonohysterography or saline infusion sonosalpingography is a very, very easy to do, user-friendly, patient-friendly investigation to assess the tubal patency. It is done on the gynae couch. No anesthesia is required. The patient is in a lithotomy-like position. Aseptic technique is used. No pre-medication is required. But if you are very keen on, you can give atropine to the patient to avoid any vasovagal reaction because of severe pain, which is not at all common. Oral antibiotic must be given as a cover. It is usually done between day 6 and day 10 of the last menstrual period. That means mid-proliferative phase, where you do not have a mature follicle and there's no chance of ovulation and the bleeding has already stopped. The bleeding, if it is on and you are injecting saline, and some air bubbles may go with it, there's a remote risk of air embolism through the open vessels, and that is why this time is selected. We usually use Follis catheter, 6 or 8 French, but there are dedicated sonosalpingography cannulas also available. I usually prefer Follis because of the balloon that you can distend. It's very easy to fix it in the just above the internal os. I would introduce the catheter, allow the balloon to pass above the internal os, and just distend it with 1 to 1.5 ml of normal saline. That is enough of amount. You don't need to do it more. Then you remove all the instruments, the metal instruments, the speculum and the anterior retractor, and if you have used valsellum, everything. And then you would you introduce the probe, naturally covered and protected with gel and condom, and then you would introduce the probe. As you introduce the probe into the vagina, you would first confirm the position of the balloon in the cavity. It should be in the mid cavity. If it's too high and touching the endometrial
Dear viewers, please stay with us. There is some network issue. We'll join you back.
So you have the people who invented or people who tried doing saline infusion, they have used a lot of, they have recommended it a lot and have compared it with laparoscopy and HSGs and have showed huge success. But you cannot see the entire tubal lumen, and you can sometimes not make out what is the side and that which side is blocked, and that is a big side disadvantage. You can use color Doppler for the same. You can use the same field of vision, and you can use a color box. And when the fluid is being injected, you will see a color gush into this box, which tells you this tube is patent. And if there is a block, you will see the fluid collecting in the uterus, but you will not see anything. Hello? Hello?
Yes, ma'am.
Am I audible? Zinat,
Yes,
was there
yes.
something you want me to stop?
No, you are audible. We are not seeing your screen.
Oh, you were not seeing the screen even then? So since when did you stop seeing?
Just now when you joined back. That's right.
So now is it visible? Not
No,
yet?
not
You want
yet.
me to share it again?
Yes.
Yes, I will do that. Yeah, can you see it now?
Yes,
Hello?
ma'am. We can.
Great. So if you are using a color Doppler, then you would inject the fluid in short jets, and you will see the fluid coming in the uterus, and you would see the color gush into the color box, and that tells you the tube is patent. Very importantly, when you are doing saline infusion with 2D, you are going to inject fluid slowly, continuously. When you are doing a color using color Doppler, you will inject it in short jets. If there is no speed, you would and the tube is blocked, you will see no color gush into the box even when the fluid is collecting into the endometrial cavity. But that also does not show you the entire tubal lumen. Though people who did this, people who documented this for the first time, they still showed a very high reliability for this test. If you want to see the entire tubal lumen, you have to see the entire, you have to opacify, you have to make the entire tubal lumen look hyperechoic, and that you can do it most easily with air. People would mix air and saline in the syringe, or you can inject saline and followed by that you can inject air. And air is truly a beautiful, miraculous medium. It shows the entire tube along with the spill, as you can see here beautifully. You will observe it again, the air collecting there in the lumen of the uterus, and beautifully you can see the spill, and that confirms the patency of the tube. Instead, if there is a block, you just see fluid collecting, air and the fluid collecting in the uterine cavity, in the endometrial cavity, and you don't see anything spilling out. But still, it is difficult to keep the records of this, because yes, of course, you can store a clip, but if you have not documented, you need to keep on introducing air, because air bubbles are very short-lived. And when that happens, the risk of air embolism increases. Because of that remote risk of air embolism, there are many centers now who do not permit to inject air, and therefore we need to use a positive contrast. Ecovist and Levovist were the contrasts which are intravascular ultrasound contrast. These were available for years and years together in the international market, but they were not easily available in India. They had to be imported. Since 2011, Breco has come out with this product, which is Sonoview, and it is sulfur hexafluoride microbubbles, and this powder is available with normal saline as a solvent. And when you mix the two, you can agitate and create microbubbles in it. You need a very small amount of it, and you can on 2D also beautifully see the hyperechoic contrast. See, you are seeing it here. The entire tubal lumen is being seen, and you can document it as a still image also. But when you use it with contrast mode, the visibility of the entire tube is much, much better. Contrast mode is available as an option on your 3D machines. You can beautifully see the entire tubal lumen, and you can also see this broadened end here, which is actually the femoral end of the tube. So you can beautifully see that femoral end of the tube also, and that shows you the entire tubal lumen is patent if there's block, where the block is, and also the condition of the femoral end. One more similar case, you are seeing the entire tube here, and you are also seeing the femora. But it does sometimes, if there is a block, you may see the media collecting, the contrast collecting somewhere in between, and you will not see the spill. Sometimes it also happens that you can see the spill. You are seeing the contrast coming here. You are seeing the spill coming here. You are seeing some contrast coming here. You are seeing the spill there, but you cannot establish, you cannot see the continuity of the entire lumen, because the tube is a mobile organ and it might not be seen in a single 2D plane. There's one more similar case you are seeing here, where you're seeing the tube here, you're seeing the spill, but you're not seeing the entire tube. And in this case, you're just seeing the contrast pooling here because of the block. You can also use, that is with the contrast mode with enhanced mode, whereas here you are seeing with the coded PI mode, where you are seeing not seeing the other details, you're just seeing the entire tube. And on the rendered image, which is still not even processed, you can still see the entire tubal extent along with the endometrial cavity. The similar thing here. So you can use different modes, even with different rendering modes, even with the contrast mode on. And when you use 3D, when you use the positive contrast, the sensitivity is not higher than the saline infusion, but the specificity is definitely better, and the positive predictive value is better. Hycosi is more efficient than the saline solution in determining the fallopian tube patency, and is as efficient as HSG and can be used instead of HSGs. It has a high sensitivity and specificity compared to HSG. Hycosi provides highly efficient evaluation. But as I told you, if you cannot see the entire tube, as we saw the previous clip, 3D is required. When you use 3D, you can see the entire endometrial cavity, both the tubes and the femoral end also. And you can also use 3D with power Doppler, which again shows the entire endometrial cavity, the femora, the tube, both the tubes. Or you can also use HD live. What I do is I concentrate on one side at a time, half of the uterus and one ovary, and you inject the contrast and you acquire a 3D volume. After you acquire a 3D volume, you can render it and use MagiCut to post-process it. I use HD Live, and I may also use Silhouette and light adjustments to produce pictures similar to hysteroscopy and laparoscopy. Similarly, you do it on the other side, and both can be cut paste on the computer. And you are seeing here one tube is hydrosalpinx, second tube is nice and normal. A femoral damage also can be recognized on this proximal hydrosalpinx here. Normal tube on one side and absolutely damaged tube with damaged femora on the other side. Chronic salpingitis on both the sides, and block tubes similar, block tubes both. And here you can see on the Silhouette mode, you can also beautifully identify or diagnose any tubal abnormalities. So these are just a few pictures for your knowledge. You can beautifully do you can beautifully demonstrate the entire tubal lumen, femoral end, and the uterine cavity. And because it's an ultrasound, you can also evaluate the tube-ovarian relationship partially. You can see the site of block, and it has been proved to be higher sensitivity and specificity than the routine 2D Hycosi, high concordance rate with laparoscopy, and it has been suggested as a primary investigation even by NICE for asymptomatic women who need tubal evaluation. and you can do this procedure. If it is normal, you can start treatment, but remember, it is after all an imaging procedure. If you find anything abnormal, it needs to be confirmed by laparoscopy. Thank you very much for your time, and we will quickly move to the our expert views for the for the panel discussion. So for the dilemmas that we often see in the infertility practice. Just give me a second and we will start sharing. Please let me know if you can see the screen. Can you see the screen?
Yes, we can.
My experts on the panel, you are most welcome again. And sorry to keep you waiting. Now, to start with, Aarti, there is a patient with 2 early trimester abortions, and she comes to you and do a scan. You do a scan for her, and that is the longitudinal view, and that is the transverse view of the same patient. So the evidence, the abnormality is very, very evident. I want, the patient has gone to Aarti, and Aarti has sent for ultrasound to Dr. Manju. And Dr. Manju, can you please tell me what we would do next?
Well, Sonal, it's very nicely showing on the transverse view that there is a separation into 2 endometrial cavities. And so my next thing would be I would immediately go ahead and do a 3D. And when we do a 3D, we can see that there is the anterior fundal contour is pretty normally seen. And there is an internal indentation, which is a septum, which is going all the way up to the level of cervix. And this is a case of a complete septate uterus. So that is probably the reason why she is having 2 missed abortions.
Yeah, so this is quite a typical case, but there are a lot of cases where we have a lot of confusion whether it is a biconvate uterus or a septate uterus. So Dr. Manju, can you please help our audience to differentiate between the two?
Yes, in septate uterus, the anterior fundal contour is basically what we look for. In a septate or partial or a complete septate, anterior fundal contour is generally normal, it's normal convex, may show minimal indentation. And the septum we can define and we can see it going ending above the level of internal os or just going all the way into it. We can measure the distance, which is the apex from the fundus to the tip interosteal line. And this distance should be less than 5 millimeters. We can measure the length of the septum from the interosteal line to the tip of the endometrial cavity. That actually is different with different classification models which we use. We can measure the angle, which is in between the from the tip of the actually, it's very nicely seen here. It's hard for me to. So if it's less than 90 degrees, these are all in favor of septate uterus. But I personally prefer using the Esri classification where the numbers are not involved. There, what we do is we measure the anterior wall thickness and the posterior wall thickness, and the septum is 50% of the wall thickness. So I personally prefer Esri classification over the ASRM classification because there are too many numbers involved in that.
Right.
And when we try and differentiate it from the bicornuate or a bicorporeal uterus, which is what is called on the Esri classification, there are there is an external fundal indentation and then there's an internal indentation into the endometrium. So the 2 cavities are seen separately. Each cavity has its own myometrium and endometrium, and there may be 2 separate cervices and there may be 2 separate vaginal canals. So that is bicorporeal, and then it further divides into a couple of further divisions into types, 3 types of, partial.
Very brilliant, very brilliant. And I hope that really resolves the queries of our audience. So we do not, if I summarize that, we do not call it anymore a bicornuate uterus. We call it a bicorporeal uterus according to the new ASHRAE classification. And as Dr. Manju rightly said, we are not using absolute measurements like 5 millimeters and 10 millimeters. We can either measure the anterior and the posterior wall and take a mean of that to decide the myometrial wall thickness, or we can on the coronal plane draw an intercoronal line and from interosseous line, and from that to the highest point on the fundus is our myometrial wall thickness, and that myometrial wall thickness is used as a standard to say how much or to calculate how much is the deformity on the endometrial contour. Can you quickly, Aarti, say about the differentiation between septate and bicorporeal according to ASHRAE? Aarti?
Yeah. So the septate has a normal external contour outline, and the internal indentation exceeding more than 50% of the uterine wall thickness.
Correct.
Yeah, that is a septate, and the bicorporeal has an abnormal fundal outline and the presence of an external indentation at the fundal midline exceeding 50% of the uterine wall thickness.
Thank you to both my experts. And so that means we do not have any didelphys anymore, right?
No.
Do we? Yeah. And didelphys and bicorporeal and didelphys and bicornuate both are now bicorporeal. Am I right? Yes, my panelists, we want a view from you.
Yeah, that's what I agree with, and that's why I find ASHRAE classification much easier, because it's very hard to differentiate bicornuate, uterine didelphys, and it just gets into one
They're
category.
right.
I agree with Dr. Manju.
And what about this confusion?
You know, this is like that type 3 where it's a partial, where it's a septate and a bicornuate type. It's bicorporeal type. Now here the wall thickness goes more than 150%, and the two cavities are widely separated. And this is like an absorption and a fusion defect, which is combined together, and that gives to this type 3 or type 3C bicorporeal uterus, and you've actually very nicely outlined it on this image.
So they call it a bicorporeal septate. So there's one more reason which I many times say lightly, that this classification is considered to be more practical because it has given name to every confusion. There was always a confusion between septate and bicorporeal, and they said, okay, that is bicorporeal septate.
That's right. Yes.
Yes.
That is really good. Okay. And therefore, that means you naturally follow ASHRAE, and I also usually prefer now ASHRAE, but if there's any confusion, even then I would take a support of the AFS system.
Yes.
So, and the best thing I think is that you can describe the cervix and the vagina separately, right? So you don't confuse things. Yeah, that's very, very true. The next case is where the patient is about 27 years. She goes for infertility management after detailed history and details of the previous treatment. The specialist decides to take her, so Aarti decides to take her for IVF. And she appears to have 12 ventral follicles. I'm sure, sorry Aarti, you are the only gynecologist available in the world for us. So she appears to have 12 ventral follicles in the either ovary. So that's a good reserve.
Yes.
On ovulation induction, she shows good follicular recruitment, and the trigger is given, and 15 oocytes were retrieved in all, and 12 embryos were formed, and 9 blastocysts. So that is quite a good scenario as far as fertility potential for her or her chances of pregnancy. Is that right, Aarti?
Absolutely. She has a very, very good cumulative pregnancy.
And what was done was that she was, 2 embryos were transferred every cycle, and 3 cycles were tried, and there was no conception. And that was a big, big frustration. So before any other investigation was done for her by the gynecologist or by the infertility specialist, she rushed for ultrasound. And she goes to Manju for ultrasound. And what do we need? So, what are the things she's going to tell us? What are the things that were in her mind when this patient came, and how will we differentiate this?
Ma'am, can I just say a point over here?
Oh, sure, go ahead.
Yeah, I meant if you're lucky to have Dr. Manju as your neighbor, then you can depend on her to diagnose why she failed. But for most of us who don't have her or you as our neighbors, I think, we do our own ultrasound and so we have to help ourselves.
Yeah, 100%,
Yes.
100%.
Yes.
You are
Otherwise,
not
all of us are not lucky to have you and
you
Dr.
are
Manju as neighbors.
you are even more lucky because you have two of us inside you.
Yeah, absolutely.
And the greatest teacher you have with you always, your mom.
Absolutely, absolutely.
So please, Manju, if you can throw some light on this.
Yeah, the first thing I would try and rule it out is if she had any Mullerian duct anomaly, which we have already discussed and we've decided that's not it. Then we look for other endometrial lesions like polyps, which are seen as focal masses within the endometrial cavity. We look for fibroids, especially the submucous. Yeah, this is a very nice picture. It's an echogenic focus. Color flow shows a dominant feeding vessel, and it's actually very nicely seen in both long axis and I would actually like to do a 3D at the same time because it documents where is the polyp. And its importance lies in the fact if it's in the mid cavity or where the implantation is going to place, it's going to hinder the implantation. So there could be a failure of implantation because of the polyp. So when we describe the site, we prescribe size, location, and then the OBGYNs have to decide how they want to deal with it. The other things, sometimes they're small polyps, and I think those sometimes, I would like Dr. Aarti to comment on it, but sometimes we just say, okay, wait and watch and then see if they hinder in implantation, then they need to be taken out. The other thing which I would like to do is to look for the submucous fibroids because those are very important because those are the other things which can give problems. And once we see these, yes, when we see these, we have to decide whether they are growing, how far they are growing into the endometrial cavity. When they're completely growing into the cavity, they are type 0, which is classified according to FIGO classification system. Then there could be 50% within the cavity, 50% in the myometrium, and then, or they could be, most of it is being outside the myometrium, and only a small part of it is growing into the endometrial cavity. So we classify them according to that, and then we look for the intramural fibroids. Are they indenting the cavity? They could just be putting a mass impression on the cavity. And these fibroids, we all know, are very well circumscribed. They may indent the cavity, and the color flow may show peripheral vessels. So that's what I would like to rule out, fibroids. Then the next thing which we would like to do is to look for things like infection, inflammation, and as uterine synechia, which is again a very common finding which we see it, especially if they've had any sort of interference. They come back with distorted cavities. They have these filling again, I don't know, I seem to be talking on 3D. You have beautiful images showing those that they are seen as synechia or hypoechoic areas within the endometrial cavity. I still prefer doing a 3D, but I think a 2D also gives you a lot of information. A long axis will show you slight disruption somewhere. And then when you go and focus that area on 3D, you will find that you are much better able to define it. And so synechia is another this thing, and tuberculosis is one of the common causes in our country. Also, we look for the interstitial segments of the fallopian tubes in the tuberculosis because they are vertically oriented.
Ma'am, one more thing is maybe I'd also search for a hydrosalpinx because
That's
communicating. Communicating hydrosalpinx can cause recurrent implantation failure.
Sure, because any time we see fluid in the endometrial cavity, we do go and look for the fallopian tube. There is no reason why there should be persistent fluid in the endometrium.
Very true, very true, very true. And so that is almost all, I guess, that we will look for. And there's one thing that there are two things that I want to ask our clinician, and that is, do all polyps require removal? What does the evidence say?
Ma'am, in women seeking fertility treatments, maybe polyps may interfere with pregnancy. And because it is known that polypectomy can improve fertility in subfertile women with even if they are asymptomatic, some experts remove the endometrial polyps even in the absence of abnormal bleeding to improve the pregnancy rates. But yes, there is a high rate of regression in polyps smaller than 1 centimeter, and maybe only in asymptomatic, premenopausal women, I would leave it alone. But if it was this patient who came to me, who you just described, everything looked good and she's still failing, and I saw a polyp, however small it was, even if she's not having any complaints, I would definitely consider removing it.
Yeah, so that's right. If you have ruled out all other causes and she still has implantation failure and a polyp is present, that means you will remove it. But you have to rule out all of it. I will really love to share one real interesting case of ours. This was a patient with multiple polyps. She came for infertility management. I was a little reluctant, but she was taken for 3 cycles of IUI. She did not conceive. On my insistence, the clinician agreed to do a polypectomy. She did the polyps. There were 3, 4, 5 polyps, more than that even. There were complete clearance was done. After the clearance, the endometrium was so beautifully developed. We did the first cycle. She didn't conceive. Again, the next cycle, when I was seeing her on day 6, 7, 8, again the polyps were recurring. There were again 6, 7 in it. And I was so upset about it. But that cycle she conceived, and that baby is already 10 years now. So you do not know how the polyps are going to behave. And therefore, yes, it's right. If you have ruled out all of the causes, try that too. Very, very true. Very true. And what is your take about the sub mucus or subendometrial polyps, subendometrial fibroids? Aarti.
Submucous fibroids.
Yeah,
No? Ma'am, submucous fibroids, it is known that they interfere with implantation. And so if I saw a submucous myoma, then I'd use the step W classification, and which will tell me about the degree of protrusion, the size, what is the extension, penetration, yes, extension to the base. So I would use, where it's exactly present, and I would use that classification to decide how to remove it. But definitely we have to remove it. Just one more point, ma'am, I meant about polyps before we move ahead. We also know that micropolyps are associated with chronic endometritis.
Very true. Very true.
So when, in such a patient, I'd also, even if I don't if I don't find any reason, why she's failing, I'd still also want to consider, and I've ruled out everything, I'd want to do a diagnostic hysteroscopy, just to look for micropolyps. Again, there was a case where she had multiple micropolyps, and, we gave her a course of antibiotics, and we also do something called as plasma cells, and she was plasma cell positive grade 3. We gave her a course of antibiotics, and of course did the resection as well, and she conceived.
Great. So we have these messages. Polyps, if they are there, you have ruled out everything, you must operate. If you don't find any other causes, polyps are important. I mean, they must be treated if they are infective, or they are they may require antibiotics. A beautiful sign mentioned by Dr. Manju, the vertical orientation of the interstitial part of the tube, which is quite specific, or quite commonly, I will not say specific, but quite commonly seen in tuberculosis, which is pointed a very good sign that you are not seeing the complete continuity of the endometrial cavity, and there may be synechy, so 2D and then 3D, very important. And then we also have a take-home message on what to do with the submucous fibroids. So that is quite a good thing. And then there's one dilemma again. How do you differentiate? There is, of course, Dr. Manju has already mentioned that in her lecture. But Dr. Manju, can you please once again tell us definite differentiating points between adenomyomas and fibroids?
Well, okay. I was waiting for your image to come. Thank you. It makes my life simpler. So just fibroids generally are very well circumscribed. They're generally hypo or isoechoic as compared to the surrounding myometrium. And if we put in, whereas adenomyomas, we can see on this other picture, are usually heterogeneous. They're poorly circumscribed. They show these pattern of multiple tiny cystic areas, and they also have the streaky pattern or in the adenomyoma. And when we put in color, there's central vessels are more prominent as compared to fibroid, which is more peripheral vessels. And there is increased vascularity on the whole in adenomyosis or an adenomyoma as compared to a fibroid. And then indentation, actually one more thing which I like about this, if it's of adenomyoma, when we are scanning in the long and we going through the endometrium, we see that it crosses the area. So it's in a fibroid, it'll get interrupted, especially if it's a submucous fibroid or even if it's in contact. Some place we will lose the endometrial lining, whereas in adenomyosis or adenomyoma, we can trace the endometrium all through while we are scanning. So it's like it passes through the thing.
Yeah, so if it involves both the myometrial
Yes.
walls, then you'll see the endometrium through and through.
Through and through,
Yeah, and also the junctional zone.
Junctional zone, that's a very, very important criteria because if it's the thickening of the junctional zone, loss of junctional zone is one of a very important criteria when we are trying to diagnose adenomyosis. And yeah, I just thought of one more thing, it just slipped my mind.
Yeah. So yes, that is quite a good differentiation. As the Musa guidelines they describe, they call it a translational vascularity for adenomyoma and an intralesional vascularity for fibroid. But these are just some more terminologies. Do you, Aarti, since you are using so much of 3D for antral follicle count, and I also do, I am a fan of that. Do you use any ultrasound, 3D ultrasound signs or softwares to diagnose PCOS? I mean, PCO, polycystic ovaries. I will not say PCOS, polycystic ovaries.
Ovarian morphology.
Yeah.
So when you see the antral follicle count more than 19
So,
with
yeah.
an ovarian volume more than 10 ml, then you say that this patient has polycystic ovarian morphology.
That's the criteria. I'm asking you, do you use any 3D softwares to
We use, yes. So we use the Sono AVC antral, ma'am, at the beginning of the cycle, as I had just shown in my talk. And, when we do a 3D, you definitely have a more precise number of follicles which can be counted, which may be missed on, actually most of the times in polycystic ovaries missed on 2D. I meant, I once took up this experiment where there was an ovary on 3D Sono AVC antral. I could count 110 follicles on each ovary.
Even I have counted maximum 95. So
yes, I mean the Sono AVC antral counted it for me. But then I did the 2D, I could count 70, 60. I mean, when I really diligently with our great machine could see, then I made another 5 of my doctors say, count it for me. All of them never crossed 70. And the Sono AVC antral, even after manual processing, I could see 110. So definitely I use it, ma'am.
Very right. And after that, pre-ovulatory also, do you use Sono AVC for these patients?
Yes, ma'am. Because one, to plan my trigger, and it gives us the correct number of follicles. It tells you about, it gives you the intermediate size follicles and the larger size follicles. I can predict OHSS. I can, decide whether I want to do a freeze-all.
Yeah, because they become quite polygonal and your diameters are not
reliable. Absolutely.
Dr. Manju, are you also using a lot of Sono AVC?
I do a lot of Sono AVC. Most of my infertility patients, once I see more than 5, I do a 3D because it gives me better resolution. It gives me number of follicles, number of size at the same time. Also, the overlap is not there. I mean, I know that I haven't measured the same follicle again.
So that's really, there are some softwares which are really a boon for infertility practice. Very true.
And the patient also loves it.
Yeah, that's very true.
Yes, they love the pictures.
Yeah, that's very true. And this was one very interesting paper which I found. This was long back. I think it was published in 1995. I came across for the first time in 2005. And very interestingly, I've tried this for more than about 50 patients, and it works. That the total ovarian volume, if it is before the trigger, if it is around 180 cc and or so, both ovaries together, the chances of OHSs are very high. But if it is 110 or less than that, no matter what is the BMI, no matter what is the number of small follicles, the chances of OHSs is pretty low. I don't know if you have ever tried it, but I'm using this since more than 10 years now, and it's really useful. That is just to point it out. But and Sonal also helps us, Aarti, if you are aware of these papers by Humadin. I'm sure you know that we have to count number of follicles larger than 11 millimeter, and again there Sonal is very helpful, right?
Yes, ma'am.
So and then coming to just quick. Dr. Manju, would you like to do it, or Aarti? What
So
are
we do it. Yes, ma'am. So we do the endometrial evaluation just before the frozen embryo transfer. So we use the Applebaum scoring, ma'am,
okay?
where based on the endometrial vascularity, we divide we divide it into zones of vascularity, ma'am. So zone 1, 2, 3, and 4. So zone 1 is when the blood flow is just in the myometrium surrounding the endometrium. Zone 2 is when the vascularity just touches the endometrial edge. And zone 3 is it reaches the internal endometrial hypoechoic zone. And zone 4 is it goes till the end. The blood flow is till the end. So we see better pregnancy rates in zone 3, zone 4 blood flow compared to zone 1 and zone 2.
Yeah. I agree with that perfectly, and I would also, I would reiterate it because I have also one study where not only the pregnancy rates are better, the abortion rates are significantly low. And do you agree with that, Dr. Manju?
Oh yeah, definitely. I prefer the study. I think it's a beautiful study, and also doing a 3D helps it.
Yeah.
Because on the coronal plane, you see the vessels going much better in the uterine cavity.
Very
and
true.
then volume. I don't know how much do you use those in the 3D indices.
You're using ovarian volume. You're asking ovarian volume.
No, the VCI.
Yeah, if it's got 3D, we get these volume indices. VFI, FI. Do you use those also, or you just?
I do use it. I do use it, but only when I have failures, at least 2 or 3 failures after I've done Dopplers.
Okay, so
and
I do the same.
I have a small study, and I have my values. And when VFI is more than 5 and VI is more than 20, that's when I get better results usually.
Yeah. So I do the same thing.
Figures may vary because we know they're still not absolutely standardized. So that's why I'm not talking of values, but yes, they are helpful for your own centers for sure. Now this is where I want you to differentiate between a few very tricky conditions where the management is absolutely different. So 42 days amenorrhea and beta HCG is just 1245, and I'm doing a longitudinal scan and I'm not seeing any gestational sac. The adnexs are absolutely normal. What do you think are the possibilities?
Well, ectopic, if you're asking me, I would look for an ectopic pregnancy or intercornual pregnancy or follow-up. Maybe it's too early, but I think with the beta HCG of 1200, I should definitely be seeing a sac somewhere.
Yes, so that's what I'm saying, that adnexs are absolutely normal.
So can we look for the interstitial segments of the fallopian tube?
That's why I did that OmniView. That's why I did that OmniView and look at that.
It's an eccentric sac.
So
that's eccentric. But I would like to rule out a cornual pregnancy, interstitial cornual pregnancy in this.
Yeah, so angular pregnancy, as they now say.
Angular,
yes, very true. And Aarti, can you please differentiate for our audience between the interstitial and the angular pregnancies, please?
So an angular pregnancy is an eccentric intrauterine pregnancy
Yeah.
with the
As we
implantation of the embryo in the lateral superior angle of the uterine
yeah,
cavity,
yeah.
whereas the interstitial pregnancy is an ectopic or an extrauterine pregnancy resulting when implantation occurs within the myometrial fallopian tube,
Yeah.
the myometrial part of the fallopian tube.
Okay, and how do you see it on the 2D ultrasound? Dr. Manju, can you please differentiate for them?
Well, on 2D, it's lying separate. We will see the endometrial cavity, and this is lying extremely at the edge and lying separate. Again, I'm a 3D person. I would do a 3D
Yeah,
because
yeah, of
3D
course.
demonstrates it very well. Here we look for the myometrial thickness, and the myometrial thickness is generally less than 3 to 5 millimeters. I think 3 millimeters is the thing. But
Yeah.
3D shows it very nicely because
Yeah,
there's
yeah,
an
of course, 3D
interstitial
is
line.
the answer. But on the transfer section also, you'll see a beaking of the endometrial
Yeah.
tissue around the mass, which tells you it is probably angular. And here you actually see a myometrial mantle between the transverse endometrial cavity and the sac, and that tells you it is interstitial. And of course, I 100% agree. Without 3D, you cannot give a definitive diagnosis. But the differentiation is very important, as we know, because the management for both is different. Here, with the interstitial, you definitely require an immediate action, whereas
Yeah.
huge percentage of angular pregnancies, they ultimately grow into the uterus. Yeah, so that everybody of us agree with that, and therefore, and that is of course, as Dr. Manju rightly said, 3D is the solution to that. And thank you very much for solving out these dilemmas with us and guiding our audience. Thank you very much, Dr. Manju. Thank you very much, Dr. Aarti. And this is a formality, let me add this to you. Both of these are so dear and so close friends of mine. In fact, yesterday only me and Manju were deciding we should not say thank you to each other, but still thank you. Thank you both.
Thank you for being such a wonderful moderator, Dr. Sonal.
Thank you, and thank you very much to our listeners. Thank you very much.
Thank you very much. There are some questions from the audience.
Please go ahead.
Yeah. Okay. Ma'am, the first question is to Dr. Manju, ma'am.
Yes.
Ma'am, can pelvic congestion syndrome mask diffuse uterine adenomyosis? How common is for both to coexist?
It is common because one of the early sign of endometriosis is severe pelvic vascular congestion and the tenderness. And if I don't see anything, I do call the patient back in 6 months to see if there's anything developing. And there has been cases where they come back and they show you endometriotic cysts. And pelvic vascular. Sonal, you agree?
Yeah, yeah, of course, of course, of course.
We've had cases.
Yeah. Okay, next question is to Dr. Aarti. Ma'am, the question is, what is the cutoff criteria of ovarian volume to diagnose PCOD?
I had mentioned it in just now when ma'am asked me.
Okay, so that's a very, very common question. So that you already have resolved the many of the dilemmas. Okay, the next question is, what is the time to evaluate corpus luteum in suspected luteal phase defect? Again to Dr. Aarti.
Sonal ma'am, this is your forte. I have learned this from you.
It has to be military scan.
Yes.
8th or 9th day post ovulation.
Okay. Okay, now the next question is, how commonly a peritoneal infusion cyst affects fertility by interfering in fimbrial ovum pickup?
So, Aarti, you want to? Please.
Ma'am, clinically, yes, it can interfere with tubovarian pickup. Two, peritoneal cysts may be associated with chronic infection, chronic pelvic infection, and endometriosis. So these two themselves are causes of subfertility.
Yeah, so that's very right. Where is the peritoneal inclusion cyst actually situated? And does it alter the tubo-ovarian relationship or not? It is on these two things that it would depend whether that would affect with the tubal ovum pickup. And of course, associated pathologies, as Aarti mentioned.
Ma'am, the next question is to Dr. Sonal, ma'am. And the question is, how much saline is to be injected at one time while doing sono self-angiography?
You would maximum require 10 to 15 cc, including both the sides. Maximum. Usually 10 cc is more than enough.
And ma'am, there is a question: how to diagnose T-shaped uterus?
Dr. Manju, go ahead with that because we've already discussed.
Well, it's very interesting. T-shape is basically it's a normal fundal contour. There is abnormality of the uterus is because of lateral wall thickening. So it narrows the endometrial cavity, and then most of the time it's very clear. You can see it. Then there are these measurements which have been come up by this CUME, which stands for Congenital Uterine Malformation Experts. So they have given these numbers where they calculate the lateral wall thickness, and if I remember correctly, 7 millimeters. Then there's a T angle which goes from interostitial line to the lateral wall of the endometrium, and that angle is I think 35. I could be mistaken on those numbers because I just keep them on my desk. And then there's a third angle which we calculate from the lateral wall of the endometrium to the straight edge of the endometrium, and that angle is about 100. Again, I would be 130, I think, is the cutoff, but maybe Sonal remembers the number. But if you want, I can.
Even I don't remember the numbers. But
yeah,
if you look at the ASHRAE SJ, they consider the myometrial wall thickness, comparison with the myometrial wall thickness. And what they do is after measuring the myometrial wall thickness, they draw a line from the cornu to the internal os. And on this line, they draw a perpendicular from the deepest point on the endometrial cavity. So this perpendicular is divided into two by this cornu to the os line. And the lateral part of this perpendicular, if that distance is more than 1.4 times the myometrial wall thickness, then they say that it's a lateral wall thickness, and then they would classify into T-shaped uterus. And in all T-shaped uterus, as they insist, the uterus-cervical ratio is normal.
Yeah.
So the next question is to Dr. Aarti. So ma'am, the question is, with TVS probe, if we do the scan, which day of menstruation AFC should be done?
So what is recommended is it should be done between day 2 to day 5 of a natural menstrual cycle. Okay, so which day of the period is between day to day 5? This is, of course, if they're having regular periods. If they're having irregular periods like in PCOS, you can do it at any time, or you can give a withdrawal and then do the antral follicle count.
Yeah, so in an anovulatory PCOS patients, they say you can do it at any time. And when you say anovulatory, they have to be 6 months amenorrhea. And so according to the definitions, and you are right, you usually do it. I usually prefer to do it day 2 or 3 only. But what do you do, Manju?
Same day 2, 3.
Yeah, day 2, 3. So many patients till day 5 you already start getting a dominance. So that's the reason. Earlier I was doing day 2 to day 5, but since about last more than 5-7 years, I've shifted to day 2 or 3 only.
Ma'am, actually, though this question seems very simple, it's a very pertinent question because just today I had a patient who's in another city, and today was her day 2 of her cycle, and I told her to go and get a scan done. And the doctor over there refused to do it, saying you're in your periods, let it stop, then come back, then I'll plan your treatment. So it's a very pertinent question. I thought everyone does it day 2, day 3, but I just got that answer today and I was so shocked.
Yeah, that's right.
So the patient was sent back. Now she's not here, so she was sent back, and now she's going to go on day 6 or day 7 after the bleeding stops.
So that's not actually an antral. Even if you look at the Rotterdam criteria and the new consensus 2018 consensus, also it always says you have to measure it on day 2 or day 3. So anyway,
yeah,
go ahead.
Yeah. Okay, ma'am. The last question. So, fallopian tubes is demonstrated by saline infusion sonography or just by 2D ultrasound?
Just by 2D, so you can only diagnose if there is fluid around or fluid inside. That means only if there is a pathology, because of fluid around, you cannot see the lumen. So it doesn't make sense. That means unless you do a saline infusion, you cannot see not check the patency.
So that's all for today. So thank you very much. It was a wonderful webinar covering all the dilemmas, which I'm sure that many of the answers get resolved by today, by the talks and the panel discussions, and now the audience questions also. So many questions have been. So I'm really thankful to all of three of you. So thank you very much for being here today with us. Thank you very much. And very much thanks to all the audience who has joined us. Thank you very much.
Thank you to both my colleagues, and enjoyed meeting you both.
Same here. And thank you, Zenith, for hosting this with your whole team.
Thank you, ma'am.
Thanks, Zinat.
Thanks, ma'am.
Bye bye.
Bye-bye. Good night.
Bye, good night.